Can you please describe what you see in this video?
Yes, this is a child. I can see a child. He's 5 years old. He's well alert, but small for age. He's having respiratory retractions, subcostal retractions as well, recessions as well, and having increased respiratory rate, limited chest expansion, mainly on the left side, and most likely this child is having left-sided pleural effusion because of the maybe it may be because of this because he's having he might be having a bronchial breathing and it could be by parapneumonic pleural effusion.
Okay. So I can see in this video a 5-year-old boy who is on hospital setting. The child is on propped up positions, 45 degree. The child is average for age. There is no any device attached. Maybe cannula mark may be present. Yes, IV cannula on the right hand. And the child has respiratory distress and someone ausculting the chest. There is dull on nature. And the left side, the X-ray showing the effusion fluid lower loop, and also at the end we are seeing that someone aspirated the pleural fluid. So it is a case of top diagnosis is pleural effusions. What are the differential diagnoses we can keep?
Yes, for pleural effusion, we can keep uncomplicated pneumonia, malignancy, heart failure, pancreatitis, and pulmonary embolism.
Yes, yes, very nice. So pleural effusion, the differential diagnosis we are keeping uncomplicated pneumonia, tuberculosis, COVID-19, malignancy, heart failure, pulmonary embolism, pancreatitis. Or they are telling the part of generalized edema nephrotic syndrome. So what history we'd like to ask?
Yes, I would like to ask about the onset, course, and duration of the disease, and also I would like to ask about for the first time. Is it for the first time he's having this, or is it recurrent, or any dry cough or productive cough, or any history of weight loss, any history of COVID contact to COVID patient, any night sweats or
Okay. History we are asking as usual, onset, course and duration, what make it better and what make it worse. Is it first time occur or recurrent occur? When was the last time? Because of chronic condition we are noticing. The cough associated, so the dry or productive cough, color and amount, timing of the cough, is it more at night? Is it related to exercise? Is there any shortness of breathing or cessation? If infant, we ask apnea,
yeah.
any musical sound, any cyanosis. Am I audible?
Yes, yes.
Okay. Does he have any chronic illness, any other concern? Fever, weight, activity, sleep. Then we are asking about problems, recurrent chest infections. If chronic, ask about previous sputum. Contact to COVID patient, travel to endemic area, contact to case of open tuberculosis, contact to COVID patient, night sweating, fatigability, weight loss, suggestive of tuberculosis, any swelling in the body or puffy eyelid. So when we take the history in video station, we are keeping in mind what are the DD we choose. So we DD choose pleural effusion associated with fever, weight can be affected, activity affected. So fever, weight, activity, sleep, and the cough associated with the pleural effusion. It is a respiratory case. So dry cough, cough description we are telling. We keep tuberculosis. So tuberculosis, weight loss, night sweating, prolonged condition, any chronic conditions, any allergic reaction we keep, any respiratory distress allergic reaction we keep. These are, and some are like vaccination history, COVID contact. Then it will be, I think, cover all the history. So what examination we do?
Yes, for this patient, we will do first we will stabilize the patient by checking the patency of the airway, breathing, connecting to the monitor, and checking for the saturations, and also checking for his perfusions, and giving IV lines, connecting with the IV lines, and starting the IV fluids, oxygen saturations, and plotting on the centile charts. And also
Yes.
for the I would like to do the complete chest examination and cardiac examination. Yeah, that's it.
Okay.
Also,
So
I
air
would like to
breathing
check for the
circulation.
BCG score.
Air breathing circulation we are doing for all times. Oxygen saturation, as it is a respiratory case, so we keep in our mind respiratory everything. Oxygen saturation, plot on the child on center. This is the vital signs: clubbing, cyanosis. Clubbing, any chronic condition like chronic suppurative lung disease, we know that. So clubbing, cyanosis important. Diseases cardiac aneurysm. Chest examination must, we are telling. Cardiac examination, sometimes cardiac examination associated with respiratory distress. So chest and cardiac examination as our diagnosis is pleural effusion. So abdominal examination for ascites, shifting dullness. And also we are seeing that it is pleural effusion evidence on the chest X-ray. So what investigation we do?
Yes, investigations. I would like to perform lab investigations and radiological investigations. Full blood and to look for any malignancies and clotting screen for to look for any pulmonary embolism case and other urea electrolytes. And blood cultures for any possible infections and
Okay,
yeah.
so we are doing, yes, full blood count as usual. It is an infection case. Keep in your mind full blood count. Then urea electrolyte. We can do the inflammatory marker ESR CRP. Then blood cultures. We can do sputum cultures. We are doing here. We are doing chest X-ray, ultrasound of the chest because of effusions. These are pleural fluid analysis. If pleural fluid there, that is analysis. These are investigation we are doing. How can we manage this pleural effusion?
For manage, we will involve the multidisciplinary team in this case, and we would like to. I would like. We would involve the pulmonologist and cardiothoracic surgeon, as well as the radiologist as well. And for this patient, we would like to start with the airway breathing circulation and start with the analgesic, oxygen, high flow oxygen, and IV fluids if needed. And if the patient is not is improving with the current antibiotic, then we will admit the patient. And if after 48 hours, if still the patient is not improving, we will change the antibiotic and repeat for the chest X-ray. It could be parapneumonic pleural effusion.
Yeah, for management, first I take the history, divides my immune route. I already examine investigations. Then management, I will involve the multidisciplinary team. That is pulmonologist, anesthesia, cardiothoracic surgeon, and radiologist, interventional radiologist. So these are pulmonologist, anesthesia, cardiothoracic, and radiologist. Airway breathing circulations, of course, on management, analgesic, oxygen, IV fluid if needed. Then antibiotic. Antibiotic, what we are choosing? Pleural effusion is it? It is, of course, I will admit the child. It's can be a complicated pneumonia also. So IV comoxiclav the treatment plus clindamycin because child is toxic. IV comoxiclav and clindamycin. If hospital acquired, actually not needed, just this line is much. Hospital acquired tazocin, tazobactam, and tuberculosis team we can involve if it is a case of tuberculosis. These are. And indication of referral to pulmonologist is that enlarged and uncompromising respiratory function, underlying cavitating disease, bronchopleural fistula. So anything when you refer, they ask that condition is not improving. We are telling that they are telling that enlarging or compromising respiratory function. We are telling that the condition is not improving after I have given IV comoxiclav the treatment. Then I will refer any cavitating disease, pleural bronchopleural fistula. So this is all about pleural effusions video stations. Thank you very much for your participations.
Doctor, did you mention the radiological investigations?
Radiological investigation, I tell you that a chest X-ray, ultrasound of the chest, we can do.
Oh,
These are,
okay,
uh,
okay, okay. Yes.
and if needed, CT chest we can do. Okay.
Okay, doctor.
Mainly we are doing full blood count. We are doing ESR CRP. We are doing urea electrolyte. We can do that. Then blood culture, sputum culture, pleural fluid analysis, ultrasound of the chest, chest X-ray, PA or APBU, and the CT chest. We can request. We talk with about it. Malignancy we are thinking. And this is the.
Mm.
So thank you very much.